In Tennessee, 1 out of every 5 children is obese, the 6th highest rate in the United States. Almost 38% of kids in Tennessee report watching TV for more than 3 hours a day. Six out of 10 children do not get the recommended levels of physical activity. The rates of overweight Latino children are nearly double that of white children. Rates for African American children are more than double. If these rates continue, Tennessee's current generation of children will not live as long as their parents.
Major funding for NPT Reports, Children's Health Crisis, is provided by the Healthways Foundation, addressing the critical issues of children's health and public education, the Nashville Healthcare Council, the Monroe Carroll Jr. Children's Hospital at Vanderbilt, getting children well on their way, Vanderbilt University's School of Medicine, Department of Pediatrics, Baptist Healing Trust, fostering access to compassionate health care in Middle Tennessee, and by a grant from the Department of Health and Human Services and the Centers for Disease Control and Prevention, as administered by the Metro Nashville Public Health Department. Additional support provided by the Orrin H. Ingram Fund and by members of NPT. Thank you.
Hello, I'm Kimberly Williams Paisley. Like all parents, I hope my children live a long and healthy life. However, in a recent study, Tennessee's children ranked among the most overweight in the country. Experts believe that if this trend continues, the current generation of children will not live as long as their parents. Why do our children rank so poorly in obesity rates? Why have rates skyrocketed in just a few decades? How can we stop and even reverse the expanding waistlines of our children? Join me as we explore the answers to these questions on this edition of NPT Reports, Children's Health Crisis.
As a young girl, Olivia Anchanda was like any girl her age.
She was very active. She cheered. She started when she was 5 and played soccer.
Like any girl her age, with one exception.
She's always been off the charts for height and weight. And because of her height, her weight blended.
Eventually, Olivia's height could not account for her additional weight.
The last 3 checkups, like from 10, 11, 12, we talked about the weight, but we tried to do it ourselves. We knew that most of the things we were eating were not healthy. Mainly it was fast food, but I didn't know how to change it because we were so busy. And as a single mother, I needed something professional, and I needed the doctor to tell them how to eat.
On the advice of her doctor, Wendy Smith worked with a nutritionist to overhaul what and how she fed her children.
I changed what I bought. I didn't have a lot of sweets in the house. If we drank Coke, I changed it to diets, ice cream to yogurt, just fruits and vegetables and things like that.
Wendy also engaged her daughters in all the changes.
At first we had to write down everything that we ate and the calories in there. And the fun part about it is we made it a contest to see who could eat the less calories, but the calories that you need every day. Obviously, Mom won. I learned from the nutritionist that when you look at the nutrition facts, it makes a really big difference. Because a lot of people say, oh, it says no sugar, no added sugar in there. But there could be fat in there that would be worse than sugar.
One of the things I learned through all of this is you have to tell your kids no. And it's okay to tell them no. And that's a hard thing to intake. But with the nutritionist, it was just to back it up and to just tell the kids from her, you're going to be told no. For some things, you're going to have to choose.
9 months after changing their eating habits, Wendy took Olivia back to the doctor.
She broke out on her leg with we thought were little pimples on her leg. And I took her to the doctor and they checked her blood levels, and her A1C level was 6.7, which is the borderline of borderline diabetic. Because it's right there, you have to be cautious. The diabetes doctor told us that if I wouldn't have taken her to a nutritionist, that she would probably be full-blown by now.
Olivia was diagnosed with type 2 diabetes at the age of 12 and now must check her blood sugars 4 times a day and take medication twice a day.
In the late 1970s, early 1980s, type 2 diabetes was never seen in children. That was the distinguishing feature between the two diabetes. We see as much or more type 2 diabetes in children now as we do type 1, and the reason for that is because there's obesity. So there's a dramatic example of 30 years of the changing of the entire epidemiology of a serious disease moving into childhood because of obesity.
In Tennessee, almost 37% of children are overweight or obese. In some counties, that rate is as high as 52%. And children follow their parents. The growth in childhood obesity rates parallels adult rates. In 2004, no states had obesity rates greater than 30%. Now 8 do. Of the 11 states with the highest rates, 10 are in the Southeast.
We have similar populations, both demographically and ethnically and socioeconomically. We have similar challenges with regards to education and income distribution. There are also cultural influences as well as societal influences. We know in the South that we use food frequently as a means of celebration and a means of gathering and recreating, and the ways that we prepare food often can be less nutritious.
This is an epidemic that most developed nations around the world are actually experiencing. We are ahead of most of them, and I think the causes for that are because we've actually gotten out of balance earlier than they have, and therefore we're having a greater impact earlier. It is affecting our adults. Over 50%, maybe even 2/3 of adults in the United States are overweight or obese. It's affecting our healthcare costs. It's affecting our absenteeism and even presenteeism, being on the job but not being able to do the job. So this is actually starting to affect our workforce.
The preventable medical costs as a result of obesity are estimated now at $145 billion a year in this country. I mean, let's put that in perspective. That's $500 per year for every man, woman, and child in this country for a preventable situation.
In Tennessee alone, if our rates of obesity were to plateau, just a plateau, not even decline, the state could save over $700 million a year in obesity-related medical costs. That's medical costs alone.
Something like 80% of kids who are obese by age 15 will be obese as adults. Then what happens is obesity dramatically increases the chance of you getting chronic diseases like diabetes, heart disease, etc.
The problem with obesity is the effects of it start right away, but the signs and symptoms that we see are much later. So in some ways, it's another silent killer. It's something which piles up over time. The later it's recognized, the less likely chance that we'll have to reverse those effects. So if a child has been overweight since the time they were 8 or 9, and now it's a young adult or 30 or 35 and they decide to lose weight, they have already had effects on their heart and on their blood vessels which may never be reversed.
We live in a state and in a city in which asthma is a big problem among children, low-income children especially. Asthma is even more of a problem in children who are obese. So you're in a high-risk environment for asthma for children, and you add obesity and being overweight into that category, and you get even more problems. Almost every obese child that I see has associated asthma as well.
Obese children can also suffer from sleep apnea, high blood pressure, early puberty, bone and joint problems, and limitations on their physical activity.
Olivia had trouble with her knee, which most of it was from weight, and so she had to go to physical therapy.
We know when we see a 12-year-old who's markedly obese, that there is no way, unless we effect change, that that child will not escape the effects of diabetes and stroke and heart attack and hypertension in their late 30s or 40s. Blindness, vascular problems in the legs, heart attacks, stroke, all the long-term complications.
With the family history of diabetes, Olivia and Wendy know well those long-term consequences. Even though Olivia shows no outward signs of her diabetes, the knowledge of what could happen provides motivation to manage her illness well now.
The doctors have told me that diabetes doesn't go away, that once you get it, you have it. So you have to, the lowest that you could check your sugar is at least once a day. And like you can't just go on not checking your sugar.
I don't think they understand the future of it if you don't take care of it now. That's why I'm so passionate about to get checked, and if you need to go to the doctor, go to your appointments. Do what the doctor tells you to do, because you can fight it, because she is fighting it.
Obesity can also lead to problems beyond physical complications.
Obesity leads to social isolation. You can't play on the sports team. You're the last person picked. You can't buy clothes at the store the same way that everyone else could buy clothes. When dating comes, you're not the person picked to date. Over time, that becomes incredibly isolating for most children. And obesity is such a problem socially for children that they oftentimes never further adapt later on in their lives, even if they lose weight.
Gabby is a soccer player. She was goalie because she's bigger and taller than the kids on the team, always. Because she was bigger, she didn't want to run as much.
Though Wendy Smith changed her family's diet because of Olivia, Gabby has benefited as well.
Once we started doing this, she saw that she could run, so she didn't want to be goalie anymore. But she saw that. Not me, not the coach. She did.
Now I can run longer, I can swim longer, and you feel better when you do it. Like at first it was just, oh, I don't want to do this. It's like, this is too much. You know, running one lap around the gym was, gosh, I don't want to do this. But now I can run 3 miles, you know, it's just, you can be unstoppable.
There's lots of evidence that even if you don't lose weight, being active dramatically improves your health. So increasing activity in kids is likely to help them achieve a healthier weight because they have not yet finished growing. But additionally, simply being more active will make them healthier. Fat is an essential mechanism for survival. In the days before grocery stores, if you didn't, succeed in killing that saber-toothed tiger for, a week or so, you had to rely on fat to survive. So the brain over millions of years has figured out how to keep those essential fat stores in place and to not let them be depleted. What do you mean you don't have any wild types? You don't have any wild type surgeries?
Right.
Okay.
Roger Cohn and his research group are trying to understand the complex interplay between environment and genetics in determining a person's weight.
Some people can live in this environment that we live in with lots of high-calorie foods all the time and a lot of sedentary activity and yet remain lean. Other people in that environment more readily become obese. So genes determine the impact of the environment on you. It takes thousands of years for genes to change. And the obesity epidemics happened over the last 30 years. Our genes haven't changed over the last 30 years, but the environment has.
There you go.
The basic cause of childhood obesity is relatively straightforward and simple. It's the balance of calories that our children are taking in each day. exceed the amount of calories they burn off through play, development, and their regular daily activities. That balance has shifted over the last 3 decades. Our kids are much less physically active today than they used to be. We have less physical education and activity in schools. Our parents are concerned about safety, so kids play less outdoors after school and on weekends. They have fewer places to go play. And our nutritional side, we eat far more calories. We're exposed to sugar-sweetened beverages. We have much more calorically dense food. Families don't sit down at the dinner table anymore. We sit in front of a television. So the environment that our kids are now living in is a much more hostile and potentially obesogenic environment.
Tammy Allgood spends a lot of time in grocery stores, not shopping for food, but analyzing how products are sold to consumers.
So imagine that a child is in this cart. Notice what they're going to be seeing that's here at eye level, and even older children are going to be seeing this at eye level. So these are the high sugar cereals that are going to always appeal to children. The appeal, cartoon characters, high color, high energy. What I've seen is that this dramatic increase in targeting children for food. Children used to never be targeted for food. Now they're constantly targeted for certain snacks or certain things that they want to carry in their lunchbox or what they want to have for dinner. Pester power is powerful. Manufacturers realize that in order to sometimes quiet a child, you'll say, okay, fine, that's what we'll buy.
Food manufacturers also responded to the increasing number of working parents with little time to prepare a meal from scratch. Convenience and fast food options exploded in the last 30 years.
Typically, there's nothing wrong with convenience or processed products. But what we're seeing is that those products are replacing fresh in the diet. And when that happens, that's when you see a spike in the number of calories that are consumed that are always going to lead to excess weight.
As families eat out more often, expectations about serving sizes have changed. Restaurants and food services advertise the value in their products, getting more for less, but the portion sizes are bigger than one serving.
Portion distortion is a huge problem. What we've seen is that a lot of people overeat as they eat out, and that translates into expecting that same serving size even when they prepare foods at home. So instead of looking at a 3-ounce portion of meat as the size of a deck of cards, it should cover half of your plate, because that's what I get at a restaurant. So we've changed how we think, we've changed how we shop, we've changed how we cook, and hence we've changed how we eat, which has changed our size.
If you look at the built environment in the southeastern states and in Tennessee, you'll see we came from an agricultural background. We have larger expanses of land, cities that in general weren't designed to be walkable, but drivable.
If you overlay a chart showing the past 30 years in the rate of growth for obesity, it's the same chart for the number of miles that we're increasingly driving as US citizens. And more research is coming out basically just pointing out the obvious, that the more we're in our cars and the more that we're driving, the larger our BMIs are growing.
We live so far from where we go to school now, we live so far from where we work now that we spend a lot of time in the car. In fact, our cities are designed so that really the only way to get from point A to point B is in a car or to have a car. And that really makes it hard for people to work physical activity into their daily lives.
What we've done is build more roads. but not necessarily make sure that we have sidewalks or bicycle paths, things like that to go along with the roads. And by only carting children around in cars, we're really reducing the amount of time that they can get physical activity. And this doesn't have to be structured physical activity. This can be riding your bike in the neighborhood, going to the neighbor's house and walking down to get some lemonade at the corner store. We're essentially building those options out of children's environments.
Nevaeh walks to school every day. She lives only a few blocks from her school.
I like to walk.
You like to walk?
Nevaeh is an exception to the average Metro Nashville student. Out of 78,000 students, only 15% live within walkable distance of their schools. But a good portion of these students will be driven or take a bus. Some for only a quarter of a mile because the streets are too hazardous for them to walk or bike. The experience of Nashville students reflects a larger trend in the U.S.
What we've done as a nation is we've moved essentially to this big box approach to building schools. Elementary schools that used to have maybe 200 children now have 800 or 1,000 children. And in order to build a school that large and to find a piece of land and to be able to afford it, school systems are finding that they have to go to the outside of the community where there's not as much development, and then they place their school there. There's a few problems with that, and the primary one is distance. You're basically assuring that children can no longer walk and bicycle to school because the distance is so great. And for a lot of kids, that kind of physical activity is really important because not all children have access to YMCAs. They don't have access maybe to sports, but going to school is something that every child has to do. And so it's just a wonderful way to get some physical activity.
The places we live, where we go to school, where we worship, where we work, really define our health in a very important way. And so we need to really kind of look at all the places where we're living and seeing what can we do to make the healthy choices more accessible in each of those places.
What we have currently in Middle Tennessee, in this state, and in this nation are pockets of environments where individuals do not have equal opportunities to make healthy choices.
And today is our kickoff to say that we're here and we're ready to sit down with people and form strategies with the help of residents who are being trained as leaders. We're getting ready to get it going. We're ready.
With enthusiasm undimmed by years of struggle, Brenda Morrow hosted a press conference and cookout to announce a renewed and concerted effort to bring full-service grocery stores to 4 Nashville neighborhoods.
You know, years ago, they tell me that there were over 20 different grocery stores in the Edge Hill community, corner markets, the mom-pop stores and stuff like that, just throughout the Edge Hill community. Then there came about this thing called urban development, and it's like everything just disappeared. Everything disappeared. There has been, since I've been here, Piggly Wiggly, there's been Winn-Dixie, there's been a Save-A-Lot, but you know, nothing stays, nothing stays.
In Nashville, there are 4 neighborhoods without a major grocery store and with limited bus service. Experts refer to these areas as food deserts.
If you go to a convenience store in a Nashville food desert neighborhood with $10, I think that you'll find it is much easier to provide for your family calories that are empty calories, chips, soda, snack foods, prepared foods, than it is to find what you need to prepare a healthy meal. Healthy food frequently costs more in general and definitely costs more in the kinds of stores where people who don't have access to a full-service grocery store shop.
I stood there in that store one day and watched a young lady come in and spend $180 in food stamps. $180 would have got her twice or 3 times that much food at a regular grocery store. and know that the only reason that she didn't go to Kroger's or somewhere is because she didn't have transportation.
They are riding the bus upwards of 3 hours, several transfers. When they get back on the bus with groceries, many of the buses aren't equipped with bins or racks, and so people have talked about having kids and having groceries rolling around a bus. The choices are limited even in terms of what foods you can buy when you're making a trip that's that long in the summertime. You're not going to be able to buy frozen foods, or you're going to have to watch the amount of milk or liquids that you purchase. For people who live within easy access of a grocery store, they eat up to 32% more fresh fruits and vegetables. Pregnant women eat a more healthy diet, which has an impact on birth outcomes. Children, adolescents, and adults have lower body mass index and a decreased chance of having obesity, diabetes, other diet-related diseases when they live within easy access of a grocery store.
But when you go and you walk down the street in this community, you see young people that are extremely huge. It's because they have to go to the tobacco stores or these dollar stores and just load up on junk that's got no nutritional value, but yet and still it's got a bunch of calories, carbohydrates, all that kind of stuff that's detrimental to these kids.
Nashville's food desert neighborhoods share a similar demographic makeup. The residents are predominantly poor and minority populations. These two factors can significantly impact obesity rates.
You begin to ask the question of why, if you are poor, are you fatter? And the answer is you go back to the issue of access.
Ready to jump up here? Jump. Ready? All right.
In the heart of North Nashville at Meharry Medical College, Dr. Excelina Bean must confront the realities of her patients' lives in order to treat them.
We can focus on meeting the child's needs or trying to meet the child's needs, but unless we meet the parents and the family's needs, then we really aren't going to be very successful ultimately. And sometimes those needs consist of, I'm living in a bad place. There's no place around where I can take this child to safely exercise for an hour. So having him stay inside or her stay inside and watch TV is actually, from my point of view, the best and the safest thing that I can do for my child. So you have to begin to address those kind of issues.
All right, let's do it.
To address some of the access issues, Dr. Bean helped build a fitness center at the clinic and recruited Meharry medical students to mentor children trying to improve their health.
That was good. Woo, you won that time. Philip, when I first met him, he was kind of, slouching down in the corner. I think at this point he knew he had a problem, but he didn't necessarily want to let me in, really. He was really fighting me. All right, and what about incline? 2.5. 2.5. We did our initial assessment of him walking a mile on the treadmill. I think it was like 52 minutes. It was very lengthy. At that point, I think he was 14 years old, and for a 14-year-old to run a mile in 52 minutes, that's just unacceptable, because it can only get worse as he ages.
Brandon met with Philip weekly.
Come on, shoot it. Oh. All right, that's one.
Building their relationship and improving his knowledge of exercise and nutrition.
Woo! We initially, before all the working out, we just said, hey, what do you eat? When do you eat it? How much of it are you eating? What should you be eating? And we kind of just let them be able to understand that these are correct foods that we need you to be eating. This is the right portion size. Some of our lower socioeconomic families, some of the reverse has been instilled in them. If it's cheap, let's eat it. The cheapest thing, as we know here in America, is not always the best thing for us. He just didn't know that all these things are bad. You can go to the 99-cent menu, get 3 things that he wants, and can be full off of that. This whole bottle is 1 can of soda. This is how much sugar you put inside your body every time.
They showed me jars that had fat and salt in the foods that I was eating, and I needed to cut back on hamburgers, hot dogs, pizzas, french fries, and a lot more things.
After 3 months of education and increasingly active exercising,
We're gonna change it again, okay?
Philip made steady improvement on his treadmill time.
He went from 52 minutes to I think like 30, 35 minutes, or it was something almost cut in half. And that was something that we really were proud of. You know, I told him, I said, hey buddy, that wasn't me. You know, you pat yourself on the back for that. You good, boy? You good. The psychological aspect, you can't take it away pretty much from any of the weight and obesity that we have here, because they're one and the same problem. If you don't have some type of support system, then you're less likely to kind of go ahead and kick yourself up there and see some improvement. All right. Cool down. I'm gonna bring it back down. Keep paddling, come on, don't stop now.
There are other issues, there's cultural issues, there's outlook for the future issues. Many of those are tied back to poverty. We have got to make additional investments in low-income communities and communities of color if we expect them to be able to make the changes that they need to make to reverse this epidemic.
We have to change the sense that disease and obesity and early death are inevitable for me because I grew up in this population. Because nothing in there is immutable. Where I live, the environment in which I live, the opportunities to move and recreate, the foods that are available to me, all of these are things that can be addressed by social change, by community development and community buy-in and initiation, by well-written policies.
The solutions to obesity are not identifying a pill or identifying a shot. The solutions to obesity are more complex, but we're beginning to realize that what we need to do is get out in the community and change lifestyles.
Within individual families, change begins with parents.
When a parent tells me that the child won't eat this, and I say to them, if they get hungry, they'll eat what you give them. The child didn't go to the grocery store and buy Pepsi. The child didn't make its own dinner. I mean, you control what it is that the child is eating, and you can decide to make healthy choices for your child.
I feel like I gained back the responsibility of their eating. You have to change your whole lifestyle. What you bring in your house, how many times you eat, the portion of what you eat and drink. I don't want the busy parents to get discouraged because they don't have that time. You have to make that time. Easier said than done, but you have to make it. It's a sacrifice.
At first, it was very hard to make the changes because you're so used to going out every night and getting something to eat. But to live longer and a happier life, you have to be able to tell yourself, I have to do it. It's for me.
I would say there is an element of personal responsibility here where parents need to be educated and understand and take responsibility. But we have to make it where the ability to exercise that responsibility is both achievable, supported, and is an easy choice to make if we want that change to happen.
I saw a 3-year-old child in clinic who was morbidly obese. He had difficulty walking. He was so overweight. And his family saw him as beautiful and really abundantly healthy. And when I examined him, I could feel that he had an enlarged liver. And when we imaged his liver, much of his liver had been replaced by fat. That happened before the age of 3 for that child. And this is why prevention and the culture of prevention needs to be a paradigm shift for us as an American society.
This is Dr. Barkin.
Hi, nice to see you again.
When Dr. Sherry Barkin started noticing the rising trend of obesity in her patients, she did what a good scientist would do, designed a study to find the best way to combat the problem.
We started actually with pre-adolescents, 8 to 11-year-olds. The idea was if we can intervene prior to puberty, that we could really impact the development of later obesity. What we found in that study is it was too late. It's not to say that it didn't work. It's a lot harder to make it work, And once you start moving in the direction of overweight and obesity, it's very difficult to go back. It's difficult to go back biologically, and it's difficult to go back behaviorally.
Dr. Barkin and other researchers have retooled their studies to focus on younger and younger children, even those in utero.
We have a lot of interesting research about how pregnancy can impact the growing fetus. For example, we know that mothers who are exposed to high-fat diets and high refined sugars during pregnancy impact the way the hypothalamus develops. The hypothalamus is an essential part of how we learn to regulate our feeding, how we learn to respond when we're full and stop eating.
Understanding how much a child should eat and when a child is full needs to begin in infancy. Bottle feeding makes it easier for parents to overfeed, which can defeat a child's innate sense of when to stop eating. Research has shown that breastfeeding is linked to lower obesity rates in children.
Parents aren't so good at knowing when they're full, but children are actually quite good at it. Breastfeeding is the best thing you can do for your child. Not only is it complete nutrition, but it also creates bonding. And because you are looking at your child, you're probably noticing instinctually a lot of cues that are the satiety cues, recognizing when your child is done. The challenge is that families are unsure if their child is full. And so in addition to breastfeeding, they will also formula feed. So a child can be overfed quite easily when you combine that approach. We're trying to help families set up habits that allow them to be healthy as a family unit. Obesity lives in families and it lives in communities. And so the solution will also lie in families and in communities.
News 2 at 5 starts now.
We think this will lay out a roadmap for all Tennesseans to begin their journey to better health.
Tennessee children and adults have a new assignment: eat well, play more.
In September 2010, the Tennessee Obesity Task Force released a strategic plan to combat obesity in the state. Eat Well, Play More Tennessee is the culmination of 4 years' work from individuals and members of over 100 organizations. The plan addresses ways to combat obesity using policy and environmental changes.
As we have in a way with smoking. I think smoking is nowhere near as cool today as it was 20 years ago. The kinds of things that that they're trying to do is to create that culture change to make it cool to be thin.
The Joint Convention will come to order.
When we make policy, we are really affecting our health. You can have an exercise class and it'll touch 10 kids, or it'll touch 30 kids, or it'll touch 100 kids. But if you change a policy so that an entire school district is going to have more physical activity, then you're touching thousands of kids. So policy, whether it's state, local, but even in the workplace, even in the churches, policies change the playing field.
If there was one thing that I could actually, wave a wand and have happen, it would be that somewhere in all policy decisions, health is considered. I think for too long we have thought about building roads with transportation dollars, educational performance with educational dollars. But if we could actually think about how does this affect the health of the citizen in everything, transportation, zoning, education, nutrition, health care, every policy, if we just had a placeholder to say how does this affect the health, then over time we would make a huge impact, because health is important to everyone. And there are opportunities for us to make positive changes that don't cost any more money.
That was a nice event yesterday, I thought. Oh, yes.
Every month, Nashville Mayor Carl Dean leads a walk in a different neighborhood.
What I'm trying to do with these monthly walks is to encourage people to get out and exercise, and the hope is that, that when I leave, that continues. Those are minor things, but you want people to start thinking about how they can become healthier. It's a good thing for the city.
While the neighborhood walks may have only minor impact on the population's health, they symbolize the kind of change Mayor Dean hopes to create with bigger initiatives.
Go deep. going deep, going deep. This. Oh, you almost had that.
We invest millions of dollars, and we continue to do so, in our public parks and recreation, so people have the ability to go somewhere and get exercise. We have put a lot of money into our greenways. We need to have spaces where people can ride bikes, they can run, they can walk, they can get outdoors. We recently signed an executive order saying that Nashville would follow a complete streets policy, which means that when we build a new street or when we do a lot of corrective action in an existing street, we'll look at all forms of transportation that could be utilized on that street. And that would include pedestrians being able to walk there. Is it walkable and is it bikeable? So when you look at transportation solutions, you would also include in that the ability to have a bikeable city and a walkable city. And clearly, the more we do those two things, bike and walk, and get away from being in an automobile all the time, the healthier we're going to be. It's the responsibility of all members of a community to think about the future and what we're going to leave behind. And we want our children to be healthy. I mean, that's just a value. If you have healthy kids, you're going to have kids who are doing better in school. Kids who are more likely to join the workforce when they're older and do well, and they also don't require as much medical care. But healthy children in and of itself is a noble goal that I think is pretty obvious that any city should strive for.
One big opportunity we see for having an impact here is changing the environment in schools. We require kids to go to school and we teach them about health and we teach them about healthy eating, but what do we actually serve them? Same for physical activity. You know, the state of Tennessee has increased the requirements for physical activity during the school day. It's always competing with other things. It's like, what are the things we can do to make healthy food and regular physical activity just a normal part of the school day?
All right, let's go. Hold my hand.
Though vastly different schools, Glendale Elementary Spanish Immersion School and Glencliff Comprehensive High School share a commitment to improving the health of their students.
So students, you have a 3-day vacation. Please make sure you do use that time to complete any missing work. And my primary job as a principal is to educate students. But I've recognized that health and recreation and access to opportunities for kids is also equally important.
For many years, there was a philosophy that the children really should be spending more time inside than outside, and that recess was too long. And so now that we're looking at childhood obesity, diabetes, asthma, physicians are also telling us that it's just as important for their brain development to have physical activity. Even having 2 recess periods a day, they come in and they're able to focus better, and they enjoy school more by having that free time.
Coming from an under-resourced community, Glencliff students face numerous health issues.
They're no different than the national epidemics, childhood obesity, asthma, diabetes, but also just nutrition awareness. A basic understanding of good, healthy, and wellness practices amongst youth is just something that's very vital. But even after educating them, they have to have access to the services in order to take advantage of them.
Both schools have embraced the Coordinated School Health Initiative that aims to improve academic achievement by addressing the health needs of students. To achieve and sustain this goal, community organizations provide support and work within the schools to address everything from school lunch nutrition to access to health care to recreational activities. At Glencliff, United Neighborhood Health Services established a community clinic to provide better health care access.
And go over and form a circle around any of the garden beds to observe.
At Glendale, a local farm and a nonprofit organization help start gardens that can be used as a teaching tool and to expose children to unfamiliar foods.
We talk about a culture of wellness, and I think that's one thing we'd like to do at Glendale. This is just what we do. We don't have, cupcakes with 6 feet icing at our birthday parties. Instead, we have book parties. The gardens become the norm. It's normal to go outside every chance we get. It's normal to recycle. So that when they go home, the hope is that they're used to recycling or playing outside or eating better in a variety of foods. Do you want a container for the tomatoes?
With a background in public health, Selena Carpenter was also disappointed in the quality of food offered in her children's cafeteria. She helped start a parents group to advocate for better food in schools.
We thought it would be a matter of, let's just change the food in our school. Of course, now we know it's part of the huge metro system. So we started working ways, what could we change? What is under our control? One of the things our group, and what I'm really interested in, is for there just to be more whole foods, non-processed, real food, as Michael Pollan would say, that our great-grandmothers would recognize.
A lot of children have at least one major meal. Many have two major meals at school. So it's the place where they're getting most of their nutrition. Nutrition, we know, is strongly related to disease and health outcomes. So this, for me, is a no-brainer. School lunch is a place to reach most children across the country. It's a place where we can reach our most vulnerable children.
In Metro Nashville schools, 71% of students are eligible for the federal free and reduced breakfast and lunch program.
One of the biggest problems is that school lunch is expected to be self-supporting. Reimbursement rates are low, so for free and reduced price meals, they are not paid much. They don't feel they can charge much for the meals for the paid students, and yet they're expected to manage an entire business.
Like most Tennessee school systems, Metro Nashville School Food Services budget comes from three main sources: federal reimbursements, up to $2.74 per plate to cover the cost of lunch for qualified students; cash sales of additional foods or a la carte items; and sales of full-price meals. Food Services receives no money from the general education operating budget. It also does not get any money from vending machines in schools. At the high schools, those vending machines can create competition for the cafeterias. After covering all operating expenses such as labor and equipment, Food Services has between 80 to 90 cents per plate to spend on actual food and milk costs.
One fallout of the cost problem with school lunch is that they tend to rely on processed foods. Labor is by and far the biggest cost to the school lunch program. So anything that you bring in that requires a lot of labor is very costly. As an example would be fresh chicken. It is so much easier and so much cheaper for those schools to contract the processing of that particular food out to a company. And that's what most do. And then it comes back in the form of chicken nuggets. And we say, why on earth are they serving chicken nuggets? Well, this is why they're serving chicken nuggets. Is it's so prohibitively expensive for many districts to manage the cost, if they even have the facilities.
Now we do some scratch cooking, but for the most part, we want to make sure that we have foods that are conveniently served. So the daily menus are planned based upon the planning guide by USDA. And then we also look at really what do kids want to eat, because we are feeding teens and young children. So we want to make sure that those menus are kid-friendly.
The food offered at public schools as part of the federal school lunch and breakfast program must meet USDA nutrition standards. The state of Tennessee also requires any a la carte items to meet certain standards.
What we've seen over the last few decades is the onslaught of competitive foods, or a la carte foods as they're sometimes known. Most of those foods are snacky kinds of foods, so processed foods that are high in fat and high in sugar and high in salt, exactly the kinds of foods that we don't want our children to be eating. The problem with selling those foods is that children will often use those foods to replace their lunch. So instead of buying the lunch, they'll actually buy those kinds of foods. So not only are they eating those in addition to their regular meals, they might be eating them instead of their regular meals. There's loads and loads of research out there showing that we eat what we eat because it's in front of us, or it's nearby, or it's tasty, or the combination of all of those kinds of things. Really, if we want to see changes in what kids are putting in their mouths, we have to set the environment up so that the healthy choice is the default choice.
In Nashville, Metro School Food Services is reviewing its current operation to identify ways it can improve, such as adding salad bars or cutting fruit for younger children, and reducing the sugar content in flavored milk. Federal policies are considering more stringent nutrition guidelines developed by the Institute of Medicine.
We like what we see as far as the change is concerned, because they reflect the increased amounts of fruits, the increased amounts of vegetables, and the increasing amounts of whole grains. But in increasing the fruits and vegetables and whole grains, that's where your most increased cost is. The challenges that we face, will our actual budget support the increased costs and the customer preferences?
I think that's another reason to remove all of these tantalizing extra treats. I mean, it's kind of ironic because we often include these competitive foods saying we've got to make our budget, we've got to make our budget. If we can sell more candy bars and more ice cream, then we'll make our budget. But in a strange way, this tends to really penalize the school lunch program, because if kids have that to buy, they won't participate as well in the school lunch program. So I think that's important to remember too, that removing those competitive foods means you're removing alternatives to school lunch, and kids will, generally speaking, eat food if they're hungry and there isn't anything else to eat.
I find it problematic that we continually insist on balancing the budget and running a business on the back of our children's health. The price we pay in the long run, to me, should be considered as part of the budget. Behavioral problems, the issues that we see with obesity in our schools, the chronic diseases, the asthma, all the things that we are struggling with at astronomical rates in this state. To act like those are not related to what children are eating is irresponsible.
There is no really effective treatment for obesity right now. It would be much more effective to prevent it. And so we do need to have a major focus on prevention.
We need to rethink our medical care when it comes to this issue of obesity as not one that is solely medical, but one that is instead societal. That means we have to consider what every sector of society needs to do to make healthy living the default option, to make it simple, accessible, and affordable to live a healthy, good life.
One way to look at this obesity epidemic is that what it is already costing us. It is costing us lives. The cohort of children who were born in the year 2000 would be the first generation of children in the United States to not live as long as their parents if current trends continue in obesity and obesity-related diseases. Can we afford not to do something about this?
While every parent must help their child learn healthy habits, our state's obesity rates are not just about how much food a child is eating or how much exercise he or she gets in a day. The rates also reflect a community where fresh fruits and vegetables may be hard to get, where physical activity may be limited due to safety, and where medical intervention is valued over prevention. If we fail to reverse childhood obesity rates, our community will suffer right along with our children's health. The solutions require all of us to engage in making Tennessee a healthy place to live. Please join me in learning more about the children's health crisis in Tennessee and what you can do about it by tuning in to NPT's ongoing coverage and by going to wnpt.net/children's health.
Major funding for NPT Reports, Children's Health Crisis, has been provided by the Healthways Foundation, addressing the critical issues of children's health and public education, the Nashville Healthcare Council, the Monroe Carroll Jr. Children's Hospital at Vanderbilt, getting children well on their way. Vanderbilt University's School of Medicine, Department of Pediatrics. Baptist Healing Trust, fostering access to compassionate health care in Middle Tennessee. And by a grant from the Department of Health and Human Services and the Centers for Disease Control and Prevention, as administered by the Metro Nashville Public Health Department. Additional support provided by the Orrin H. Ingram Fund and by members of NPT. Thank you.